Hi everyone, my name's Helene and I work at the PHN alongside my colleague Jade, and we'll be in the back end of the webinar doing that today. So welcome, and I'd like to begin by acknowledging the traditional owners of the land in which we meet today. I would also like to pay my respects to elders past and present. So welcome to today's webinar, our spirometry update, and thank you for attending. Just a little bit of housekeeping. The majority of our webinars events are recorded and freely available on our PHN Learn YouTube channel. We do have a practice communique that goes out to all practice fortnightly. So there's an external and an internal calendar included in that. So have a look at all our good meetings in that. For today's meeting, all participants will be put on mute for the course of the event. Should you have any questions, please type them in the question box and I'll address those at the end of the session. They will all be answered anonymously, so yeah, just pop them in there. Could you please make note of the West Vic Health pathway relating to this topic that is on the screen at the moment. So our presenter for today is Sarah Baum. She's the Director of Spirometry Training Company. This event is being coordinated in partnership with Asthma Australia. Thanks, Sarah. I will now hand over to you.
Thanks, Helene, and thank you for the invitation to speak today. I'm just getting the right screen displayed. And we're ready to roll. So today I'm going to be talking about spirometry and some things that have changed in the past couple of years. And this includes not just the international standards, but also some obviously infection control issues that we've all faced due to COVID-19. So just a quick overview of what I'd like to take you through today. We'll start off with just a quick overview of spirometry, just a refresher on what this test is about and what we're looking at when we measure spirometry. We'll discuss the international guidelines as you possibly already know them, and that would be looking at the 2005 guidelines. And then I'd like to present to you what's changed. And in 2019, the international guidelines were updated. So I'll take you through the changes that have come out of those new guidelines. Then we'll touch on some COVID-19 issues and considerations that we've already probably encountered, but just some new things we can consider moving forward when we're measuring spirometry in the pandemic and beyond. And then lastly, if there is time, I'll be just showing you a few pictures of the virtual world of spirometry that's been my world obviously over the last couple of years. So we've still adapted to COVID-19. Training has continued and been very effective using Zoom. And we've also even been able to do testing via Zoom. So I'll just show you a few screenshots of that at the end, time willing. So what is spirometry? You'll be very familiar with it, and no doubt your reason for attending today is to hear the newest updates. But what is spirometry? A quick overview. It is the most common test of lung function, and it's the test that we use to measure the movement of air in and out of the lungs. With spirometry, we'll measure a volume of air, and we measure that in litres, but we also measure the speed of air, so that's a flow rate. And as you know, some diseases will slow down the speed of airflow. If we have airway narrowing, that's what we see. And other diseases will reduce the volume of air. So with spirometry, we can identify a pattern, and we can identify, do we have a normal result, or do we have a pattern that indicates airway narrowing, or do we have a pattern that indicates a reduction in volume? The device name is a spirometer, and obviously the test name is spirometry, and it's the global gold standard. If you're going to diagnose COPD and asthma, the global standards require a measurement of spirometry on file to do that. To do spirometry well requires 4 components. We need a subject who's cooperative and who understands your instructions. We need equipment that's accurate. We need operators of the equipment who understand what they're testing, but also how to use that equipment. And also, very importantly, we need someone who understands what those results mean and how to interpret them, and then go ahead and manage the subject or the patient with those results. And it could just be a malfunction in one of these factors, and that leads us to a poor quality spirometry. and with that might be a misinterpretation or a mismanagement of the subject. So obviously we're always trying to avoid that. Spirometry, as you know it, is possibly as you see it on the screen here. When we're using a device that measures expiration only, we take a rapid and maximal inspiration, pop our lips on that mouthpiece and blow out as fast and as hard as we can, and then we continue exhaling until the end of test when we are empty. When we measure spirometry, there's a number of parameters that are available on your devices. We really only need the key 6, and they're on your screen right now. The first 3 are the ones we use to interpret the results, and the last 3, they're the ones that will indicate the quality of the test. But together, we need to make sure all these parameters are measured accurately to have a great interpretation of lung function. The 2 displays that we see on our spirometer are on your screen right now. On the left, you'll see the flow volume curve, and on the right is the volume time curve. And they both have a role to play when we're doing the test, and they are both shown real time during the testing as well. So let's take a look at this flow volume curve. This is a display of the flow rate in relation to volume during the test. So remembering at the start of test, we're taking that full breath in, and our lungs are full at the position of 0, 0 on this curve in the corner. We immediately blow out fast with a blast of exhalation, so we get this high peak flow, and then we continue to exhale until our flow rate drops down to 0, and that's where our lungs are empty. This is the curve that's most useful to observe during the test because it will show us the technique of the patient. There's a lot of information we can get from the shape of this curve. Did you know that the shape of this curve can change quite significantly depending on the following factors? Patient technique will change the shape of that curve. Ideally, we'd like it to look like the one on the screen. However, the technique of the patient will definitely change that shape. Some patients have a variation of normal, so they'll have maybe a little bump in their curve, and that can change this shape again, and for them it's normal and a repeatable shape, but that definitely gives it a bit of an alteration to this typical triangle. Our age can also change the shape of the flow volume curve, and then also a disease will change that shape. So it's a very significant curve which tells us a lot of information about not just the technique but also the health of someone's lungs. Here's the effect of aging on that normal curve. So you can see in the younger years below 30 we observe a knee or a high flow rate, and then middle age we get this typical textbook spirometry triangle flow volume curve, and then as we head towards 70 and beyond we start to get a bit of a scoop, and that's because of the elastic properties of the lung that change with age. Young lungs are nice and springy and exhale quite rapidly, and then the older lung is getting a little bit more floppy and we become a bit obstructed with age, and it just takes that little bit longer to exhale. On your screen right now, you'll see a lot of examples of different shapes of flow volume curves, and as already indicated, they'll give us a lot of information about the subject. They'll tell us, is this good quality? Is there an extrathoracic obstruction? They'll tell us, is there an abnormality? Is there just a little variation of normal here? Lots of information to gain from that flow volume curve. The volume time curve is a display of the volume over time as the patient exhales, and it's most useful to observe just to make sure we get the correct exhalation time. And as we know it at the moment, in spirometry, we exhale for at least 6 seconds for adults and up to maybe 15 seconds. Let's now look at these international guidelines that you'd be aware of that were released in 2005. A quick overview of those now, and the ultimate goal when we're doing spirometry is to achieve the best quality we can for every subject that we're measuring. And that's what these guidelines provide. They give us the framework to work within, or the criteria on how to judge a good quality test. And the quality of our test is determined by how closely we follow these international guidelines. The guidelines describe acceptability criteria and repeatability criteria. No doubt you're familiar with those concepts. They've been developed by the ATS and the ERS, and that's the American Thoracic Society and the European Respiratory Society. And a lot of global societies subscribe to these guidelines, and they sort of dictate the framework for most of the standards around the world. So Australia and New Zealand closely follow these guidelines. So very quickly, acceptability criteria is when we look at the curves and we decide, does each curve look like it meets the standards, and those standards is what are called the acceptability criteria. So do they meet the standards for a good quality start of test? Is the middle of test good quality without any coughing or glottic closure? And did we achieve a full exhalation at the end of test as well? All that criteria needs to be met in 3 efforts, and it might take up to 8 attempts to get there, but we need 3 trials that meet this acceptability criteria. Repeatability criteria is when we look at our 3 good tests and we decide how closely they match. We can overlay the curves and that'll give us a little impression of how closely they match, but what we also do is look at the parameters. And we observe the 2 best FVC and we make sure they match within a certain volume range of 150 mils. And we're also looking at the 2 largest FEV1, making sure they match within 150 mils as well. Performing spirometry is quite a process, as you can see, and on your screen here's a guide to performing quality spirometry, and I've provided this for you as a handout today because it's a really nice summary to make sure all the steps to getting a good test are covered. It's also a really good training tool if you have new staff in your practice and you want to make sure you can teach them everything about the process. Performing spirometry well does require following all these steps, and obviously we won't go through them all today. We do that in a training course. But I have broken it down into before the test, during the test, and after the test. And then I want to tell you what has changed. And those ticks that you can see there are the components that have changed with the update to the standards that have just been released in 2019. So let's talk about those new international standards now. They cover a few more issues in detail about the device. So what's new regarding your spirometer is that all spirometers now must meet the ISO standard 26782. And so if you're in the market for a new device, always make sure it meets that standard. They now focus on devices that are capable of inspiration and expiration. And the reason for that is because there's a heavy focus now on measuring a breath in at the end of the test. So after complete exhalation of spirometry, we now introduce an inhalation, just as rapid and just as full at the end of test, and we call that the FIVC. Devices now need to record the date and time, not just of each test, but also of the time that's elapsed between pre and post bronchodilator. And they've also now required to provide automated feedback, but a standardized way. So there's new requirements to provide this uniform feedback, and that's to assist operators. It's also now required to give you a warning alert. So at end of exhalation, we need to hear an audible and sometimes visual alert so that we can identify that the subject has met end of exhalation. But it also should be alerting us now when the calibration is out of limit. So there's some really great updates to requirements for devices. Some of you may have updated your software on a device recently and noticed some changes, and that would be because of these new standards, and all the devices are trying to conform to those new standards and slowly releasing updates in software. So you might be aware of some of these changes already. The new requirement is now also to have a default reference value. So that's always been a big question, which reference values should we use? It's now recommended in these standards that we all use the GLI Quanja reference values. You may have already heard of these. They've been around since 2012, but very quick summary here. These are the newest data set that we have for what normal spirometry looks like. They cover 26 countries. We've got multi-ethnic data now, and it also breaks down the ethnic categories for us. It's a really robust data set. It almost has 100,000 records. And almost an even spread of males and females. And it covers all ages. So previously we had a pediatric data set, maybe from age 3 to 15 or 16, and then we had an adult data set from age 18 and beyond, and sometimes it just didn't match up in the middle. There was a bit of a gap and no data for sort of 17-year-olds. Or when they did match up in the middle, there was a really big change between pediatric to adult predicteds, and so it was quite messy, but now we have one data set which covers pediatrics and adults. So that's great. And now the focus again is on the lower limit of normal. So when we're interpreting results, we're really focused on the LLN. For operators, there's a new focus on the role of an operator, and the new standards outline the requirements that the operator really needs to engage with the subject to get the best result. They liken the operator to a personal trainer. So when you're at the gym and you have that encouragement on the sideline, that's what the operator of a spirometer should also be doing. And to get to that level, obviously training and experience will greatly assist you. There's also a focus now to attend training courses to learn about the international best practice standards, but also to understand how to manage results that don't meet the standards, and to also make it a consistent approach across, well, globally, but certainly within each region. And it also focuses on maintaining your competency. So not attending a course 20 years ago and assuming that that's still valid, but actually having to demonstrate ongoing competency by attending refresher training and other things. And just a note on that, Australia is underway in developing a pathway for certification. So in a community-based healthcare setting, such as primary care, we're now looking at having a pathway to meet certification, and that'll evolve over time, but it's certainly on the horizon. Occupational Health have actually spearheaded this. They've already mandated spirometry training across a number of industries, including coal and silica. For the subject, what's new? There actually was a patient perspective captured in these standards, which was a really impressive outcome. What that has led to is some key things in the device settings. So having an audible sound to indicate end of exhalation is actually in response to the patient perspective. A lot of complaints when they surveyed patients was that we don't know why we're continuing to blow and we don't know when to stop. It's uncomfortable for us. We'd like some sort of visual feedback so we know, that the end is near. And so that's been adopted into the device requirements. Positioning and comfort of the subject was also addressed, suggesting to make sure that they're in a quiet and comfortable environment, making sure it's not in a waiting room and separate from other patients who are also doing tests, having water available for them, and also tissues to manage coughing and sneezing. And also recommended to have them in a seat with arms, okay, for any episodes of syncope that might happen during the test. I just now want to show you what's changed during the testing. So if we're looking at before the test and preparing to do spirometry, a couple of things you need to know. Before spirometry, the following is new. It's now a requirement to do a daily calibration check, and you may have already been doing this. However, there are a few other things to consider. A few different focuses for demographics. Contraindications list has been updated, and we also need to make sure we're taking a good bronchodilator history. So let's look at this a bit more closely. For calibration, if you are using a spirometer that uses a pre-calibrated mouthpiece, typically these were marketed as not requiring calibration every day, and it was quite an attractive sales pitch because it was a spirometer that then didn't need a calibration syringe to use it. However, that's no longer the case. It is now a requirement if you're going to meet these international standards to do a daily check of the calibration. So you're checking that those pre-calibrated mouthpieces are still in range. And if anyone is using an ultrasonic spirometer, you'll know it's not possible to calibrate that. But again, a check of that calibration or that it's working within its limits is required. And that's on every day of use. It's also been recommended that we maintain a calibration log to demonstrate that the daily calibrations are actually being performed. And the calibration error limits have been tightened, and you might not notice this, but currently it's a 3.5% error limit on a calibration. That's just been tightened to 3%. This will be something that automatically happens in the background if you update your software, or if you have a newer spirometer, it's possibly already there in the settings. For demographics, there was just a new outline about birth sex. So we need to call it birth sex, and this should actually be included in the patient information when it's being requested that we perform spirometry. So by the physician requesting that. Otherwise, the operator will need to ask for this information, and we encourage operators just to remind patients that we're only asking birth sex because we need to determine your predicted lung size, and that is a requirement because males and females have different lung sizes. But subjects do need to be reassured that gender identity is still respected, and there is also an opportunity to express that if they want to. Contraindications, or a risk assessment, we also call that. There is a new list now of relative contraindications. It's not that different, but it does give a little bit more guidance in how long we should wait before doing a test and this sort of thing, and also the potential consequence if we proceed with testing when there is a contraindication. It does provide additional advice now that we should discontinue the test if there's any pain experienced by the subject during spirometry. And we also just putting that focus back onto the interpreting physician, that if you're, the requesting physician, if they're asking us to perform spirometry, hoping that they can weigh up that risk-benefit ratio before requesting it, but certainly making note of any indications on the request form, so that can be addressed at the time of testing. It is still required, though, as the operator, that you ask the subject some key questions before testing, just to make sure there are no contraindications to the test. And if none are identified, you add nil contraindications to the report, just to reassure the interpreting physician that that question was asked. Here's an example of how you might like to capture these questions. We're breaking it down into cardiopulmonary questions, surgical questions, infective questions, and then anything else. And really, you just need to check, have you got a history of any recent heart or lung conditions? And if they say no, we'd go to section 2 here. Have you had any surgical procedures in the last 3 months? If it's yes, we want to break that down and identify, was it eye, middle ear, sinus, thoracic, abdominal, or brain surgery? And there's different wait times depending on what their recent surgery was. Also different consequences. So you'll see in this final column, these numbers relate to the potential consequences on the right here, and that needs to be weighed up by the doctors as to whether the risk-benefit ratio is there. And then finally, we ask the infective questions. Now, we're probably already doing that with our COVID screening as well. Other questions to consider: has the subject done the test before? Did they experience any adverse events such as syncope? Was there any recent concussion, any cerebral aneurysms? And if they're pregnant, late-term pregnancy is now considered a contraindication to the test. And for our bronchodilator history, they've re-emphasised that it's important that we give subjects instructions when they make their appointment on withholding their medication prior to the test. So there's new withholding times that have also been described. Previously, SABAs, short-acting beta agonists, we were withholding them for 4 hours. Now it's 4 to 6 hours, the recommendation. Long-acting beta agonists, we were previously withholding 8 hours. It's now recommended to withhold those for 24 hours where possible. Of course, if the subject attends to do spirometry and you've found out they didn't follow those instructions of withholding the bronchodilator, then you must make a note on their report of what medication they've taken, the type, the dose, and the time they've taken that medication. And again, best practice, if they haven't taken puffers or they don't regularly take puffers, nil bronchodilators is really good to write on your spirometry reports for the interpreting physician to know that. All right, during the test, a couple of changes as well, so let's have a look at those. What's new during spirometry? So a little bit of a change to the acceptability criteria and the end of forced exhalation criteria. So that's a new title. Previously, this was called end of test. So let's take a look in a bit more detail. The acceptability criteria have been updated. They now include something called usability criteria. I'd like to say this is dangerous. In the wrong hands, usability criteria could be really mishandled, and I really strongly recommend that you ignore usability and you stick to the acceptability and repeatability requirements as you know it. An example of usability would be if someone performed the test well at the start but not at the end. They might say that the peak flow and the FEV1 were usable, but the FVC that we measure at the end of test was not. And this is sort of where we start getting a bit of a grey area. So like I say, in the wrong hands, that can be dangerous, really only applicable in a respiratory department with really experienced scientists operating the equipment. I'm only telling you this now because I would imagine in software updates in the future, and certainly already I've noticed, usability criteria is used in the settings. And so you'll start becoming familiar with this terminology. So just keep your eye out for that. Another change to the acceptability criteria is it's looking at measuring the FIVC. And as I indicated earlier, that's the breath in, the inhalation at the end of the test. It's now encouraged to perform that where possible, ensuring that infection control is covered and that your device is capable of doing it. And the reason we like this now is it really gives us a good indication of the test quality. It also can indicate some extra thoracic obstructions that we can look at in a respiratory setting. As we know it, spirometry has just been expiration typically in primary care. However, what will change is that you'll start the test on the machine, taking that full breath in, blowing out as fast as we can, continually and completely, And then right at the end, when we are at the end of exhalation, we would take a rapid and maximal breath in at the end before we come off that mouthpiece. So that's what you'll see. If you can add an FIVC in your measurements, it's a great thing to do. And the end of forced exhalation, it previously was called end of test or EOT. This has changed slightly, and I'll be hearing you applauding with this news that there'll be no more 6 seconds of exhalation mandated. Which is great news, because a lot of people were pushing exhalation for 6 seconds, and some people aren't capable of blowing beyond 4 or 5 seconds, particularly in the younger adults who have really springy lungs and they are really efficient at emptying. So that's good news for them. However, it's still got to be observed that they get to their end of exhalation, and that's by observing the plateau. So we're looking at that volume time curve, and we must be able to confirm that there's a plateau before you can end the test. When your software is updated, or if you purchase a new device, you'll get an audible or visual signal when the end of exhalation is detected based on that plateau. And what the sensor will determine is when there's been no change in volume for a second. If some people have narrowing of their airways, it can take them a long time to exhale, and they might proceed beyond 15 seconds, but we now say just cut the test off. If they get to 15 seconds, that's plenty of information and very clinically useful, and it's quite useless proceeding beyond 15 seconds. So we cut off the expiration time at 15 seconds. So that's the new criteria. We must meet a plateau on the volume time curves. And if we haven't achieved a plateau, but we have been expiring for 15 seconds, that's also acceptable there. All right, and then lastly, let's look at the end of test. Something that's now required is for us to add operator comments. Now, this has commonly been in place. However, it's a real focus of these new standards, and they give us a little bit more information about how to write our comments. They give us some grading criteria to assess the quality of a test. So operator comments should be added to all spirometry reports. And what the idea of this is it's going to give some confidence to the interpreting physician on when they're looking at those results and determining how to manage their subjects. So just a little overview. Here's a quality grading matrix that Spirometry Training Company have developed, and it's just to make a really easy, user-friendly approach to making a quality comment for a spirometry test. As you know, we need 3 acceptable efforts, and we'd like to see the 2 best of those efforts matching and being repeatable within 150 mils. And if we do get 3 acceptable efforts on this matrix, and we can see that the 2 best are within 150 mils, we give them an A grade of spirometry. If we only get 2 acceptable efforts according to this matrix, but they're both repeatable within 150 mils, we get a B grade. The green indicates the clinical reliability is probably very reliable. If the variability is a bit larger and we can't get it within 150 mils, but it is within 200 mils, we can allocate a C grade, and possibly this is still quite clinically reliable, but do use caution. And then if the variability is larger than that, we're applying a D and an E grade. And that's where you've got to be very cautious using those results to manage the subject. Okay, moving forward now and just quickly talking about spirometry in our COVID world. A couple of resources that might be helpful for you as well. So it comes as no surprise that spirometry is associated with a higher risk of transmitting COVID-19, and that's due to the aerosolization of particles and the increased coughing that spirometry does provoke. So our goal is to minimize the risk, and certainly in the peak of this pandemic, we're only testing when it's clinically essential. So spirometry did sort of slow right down during COVID and only used for urgent treatment decisions. When we did perform the test, of course, we had to really increase our infection control measures. And based on that risk assessment of, people with COVID, obviously we wouldn't be testing them, but in the peak of a pandemic, the risk assessment will be different to when we sort of plateau out again. So where do we get advice about testing, whether we should proceed or not? The Thoracic Society for Australia and New Zealand, they've recommended that we seek guidance from your local infection control departments and your local state and health departments as well. They also recommend contacting your local labs, your respiratory labs. If they're a TSA NZ accredited lab, they'll be very willing to provide advice for your area, because obviously it's an evolving situation, and each region is going to be on a different level of risk. Now, there's also been a new task force developed by a group of clinical experts, and that's an Australian group. So the website's provided here, www.covid19evidence.net.au. This is your go-to for up-to-date clinical guidelines. They are regularly updating with the latest research, and they've developed evidence-based guidelines. So it's a really great resource. If you haven't already seen that, please have a look at that, spend some time on that website this afternoon. It's a really great resource. What they've done is something that I think is very helpful. They've developed a decision tree for whether or not you need to use PPE. So here is a quick snapshot of that. Basically, you'll assess the level of risk for COVID. And if it's a low level of risk, they just say go for standard precautions of infection control. If the risk is a little bit more high, you'll be either following a lower risk protocol, or you'll be jumping over here into this higher risk. So if you've got individuals with no epidemiological risk factors, but symptoms consistent with COVID, but at that time there's no local known transmissions, then you might approach it on a low risk setting. However, if there are known local transmissions, you'll take it up to that higher risk. And so it helps you decide what type of PPE to be using. So I think that's a great resource. I've cut and pasted it to fit on the slide. It's actually a double page. The back of this gives you a little bit more information about the example scenarios and things, and also what is standard precautions and so forth. Making sure you do the correct donning and doffing and all this sort of thing. So strongly encourage you to check out that website. Other recommendations to manage infection control during spirometry would be doing that COVID screening questionnaire and a temperature check before anyone is tested in your service. No doubt you've already followed this pre-pandemic, but the hand hygiene still remains a critical way of minimising spread of infection. Cough etiquette has always been something we've taught, and was historically really hard for me to find resources to put up around a respiratory lab to remind patients of the need to have cough etiquette. But now there are posters so freely available on the internet. So just download posters to remind your subjects of the importance of cough etiquette, making sure we're always wiping surfaces. The ventilation is important. Just remember there's a blast zone in spirometry wherever the air comes out and lands. If they're facing your desk and you've got your coffee cup on your desk, that's a blast zone, and that area should be treated as a contaminated space. The implementation of barrier filters has happened quite commonly in a respiratory lab, but with the pandemic, it's been recommended in primary care as well. PPE is obviously another way that we can control the spread. And so I'll just quickly take you through a few of the slides just with a bit more detail. So hand hygiene, that's before coming in and then before they exit the clinic room where you're going to be doing testing. Making sure we perform hand hygiene after a cough and sneeze, and observing the National Hand Hygiene Initiative, getting yourselves a certificate on that website. Here's an example of a poster that you might put up in your setting just to remind people of the importance of cough etiquette. Having tissues readily available is also an idea, and even giving it to them before you start the test. Have them holding a tissue before you start the test could be a great way to manage and ensure that cough etiquette is followed. PPE, so the hand hygiene, the gown, the mask, the face shield and the gloves, making sure you observe the correct donning and doffing of that. Wiping surfaces, as I've already mentioned, and that's including chairs and stadiometers and door handles, scales, etc. Using approved products as well with your devices. Just be mindful of checking with your manufacturer of a suitable product that you can use to clean your devices. Here are our barrier filters. There's a different size outlet depending on which device you're using, and the barrier filters will reduce the risk of cross-infection. They're antiviral, antibacterial. They also protect the sensor, and obviously they're also protecting the operator. So it's a really great barrier that we can introduce, and I would think will be our new normal in testing spirometry. However, if you've not used barrier filters before, you do just want to make sure that you're using them correctly and they're not creating a difference to your results. So what we recommend is documenting the date that you start using filters in your maintenance logbooks, and that should be something you've got with your spirometers. if this is something you're going to do permanently, make sure your procedures manual reflects that this is a common step in taking your spirometry measurements. Before you test any subjects, good idea to make sure there's no difference in measurements with the addition of a barrier filter. So you'd use maybe a couple of staff, you'd measure yourselves 10 times with a filter, 10 times without a filter, and take the average of each of those 10 results, making sure those averages are not too different. And using those averages as well to check with your usual biological control error limits if that's something you're already doing in your service. Where possible, it's really recommended that you add the barrier filter when you're calibrating your spirometer as well, so that if you're handling disposable mouthpieces before you give it to your subject, keep the plastic wrapper on so you're not handling where they're placing their mouth. But then, of course, at the end of the testing, when it's now used, you could ask the patient to remove it and put it in the bin, or you're going to use paper towel or gloves to remove that, and obviously following the hand hygiene after the removal of that. The contaminated mouthpiece. And now I'll just show you a couple of pictures of virtual spirometry world. We have been continuing to train throughout the pandemic, so 2 years of training now, almost, 18 months of training in a Zoom setting. So I've had permission from some participants recently just to show you some slides of what that's like. And you'd be surprised of what we can achieve via Zoom. We've been able to get some excellent training delivered. We've also been able to help people in their individual settings, change settings on their devices, because we're working with each participant in their clinic on their device. And so we can help them make sure their device is set up specifically and correctly for the test. So as you can see, they're just small groups. We're testing each other, so we've got a couple of people there as the patient, and role modeling the instructor as well. So it's a really effective way of testing, of training. But we've also been able to do some testing. So there's been cases where we can send the device out to a subject who's obviously signed consent and agreed to cover any damage if anything goes wrong. But we've been able to have someone download software, measure their own spirometry in their setting while we log in over the internet. And so this is our new world, and yeah, we've been able to overcome a few hurdles despite COVID. So thanks for your attention. I hope I've tried to talk quickly so I didn't go over time, but I'll just hand over back to Helene and Jade in case there are any questions that have been asked throughout the day, throughout the session.